Okay, precisely 11 o'clock. I think we're going to start. It's a great pleasure to have you here this morning talking about pelvic injuries and potential diagnostic and therapeutic approaches and possibilities. It's a great honor to share this again with my friend Jacques Duranteau from Paris. My name is Marc Maegele. I'm a trauma orthopedic surgeon, emergency physician from Köln. And we have done this last year on another topic, on viscoelastic testing and on chest injury, as I recall. And given that experience, I think this should be very interactive because the overall format tells us this should be a meet the expert session. So you should meet us, we should meet you, and it should be interactive. So please get into interaction. I know there might be different ways, different avenues, different approaches on how to deal with pelvic injuries being executed around the world. So please share the experience. I think we're going to start.
Yes, it's very important to feel free to ask a question and to interrupt us, just because the management is very depending on your facilities and your experience. So feel free.
So we prepared a couple of slides just to have something like an outline about several ideas what we would like to discuss with you within the next 30 minutes. I think we start. Can we move the first slide on the screen? Oh yeah. So basically just to give you some flavor, what we deal with in practice. So pelvic fractures, they make up 10 to 15% of all trauma. They might be associated with injuries and mostly intra-abdominal, urogenital, that also have some impact on the way how we assess and how we diagnose pelvic injuries, and obviously due to anatomical features. There is also sometimes pelvic nerve vascular injuries involved. And obviously, one of the major features of pelvic injury is blood loss. And this could be due to a vessel injury. This could be bleeding out of the bony structures. And the problem actually that we do face in pelvic injuries, that once the pelvic ring is disrupted, there could be counter pressure from other anatomical structures is basically diminishing. And so the volume of the pelvis can substantially increase. And this can be obviously, if there is an active bleeding source you're not able to control or to counteract, this can lead to an increased blood loss into the pelvic volume, and this ultimately can lead to hemorrhagic shock with all the consequences around. And once people die from acute exsanguination, they do this usually very fast, within the first 4 to 8 hours, median 1.65 hours. And insufficient hemorrhage control of the bleeding source, control of the bleeding, restoring hemostasis, failure to restore hemostasis in those patients has repeatedly described as one of the main clinical errors that ultimately leads to early trauma mortality. And the sooner we get control of the bleeding source and we sooner get control of the hemostatic disturbance and failure, the better it is obviously for the outcome. And this has nicely been shown by this subgroup analysis from the US-based PROPA trial on 400 patients that with every 15-minute in decrease to hemostasis, this was clearly associated with a survival benefit and less secondary complications. And obviously, I don't know, who is involved in pre-hospital care? Okay, so, and this has become a mainstay, and one of the major features translated from the military experience of the past into the civilian arena, to use first tourniquets for bleeding extremity injuries, but also pelvic binders. And this is clearly outlined also and emphasized by the European trauma guide that's currently being updated. And Jacques is also a member of the steering committee of this guideline. This is, again, strongly emphasized. But there is one feature and one major mistake. I don't know, Jacques, if you see also this quite frequently, maybe in Paris, in your resuscitation unit, that pelvic binders are not used appropriately. They are being used either too high or too low, and they're not placed on the trochanteric level, because that's where they exert their major force and their major action. And this is also highlighted here with the pelvic ring not adequately placed with an open symphysis. So because what you'd want to do actually with the pelvic binder is you want to close the pelvic ring. You want to reduce volume, you want to increase counter pressure against a potentially existing bleeding source within the pelvis. And as you can see here, another one was then applied to close the pelvis. And again, this highlights this. And there is obviously commercial pelvic binders available, and at least in my country, in Germany, also in France, they are available throughout every EMS service throughout the country, both in the air and on the ground. You want to guide us a little bit? In hospital, once the patient comes into the hospital, Jacques? No. Okay. So in hospital, obviously, who's ATLS trained? Everybody is ATLS trained? Okay. So the basic, even in bleeding trauma patients and pelvic injured patients, there is this structured approach to the injured patients, usually following the ATLS taught ABCDE or CABCDE, where basically C, circulatory problem, control the bleeding source first, gets a higher priority as opposed in the classical scheme, treat first what kills first. That's the major topic. Secondary survey obviously is a more or less comprehensive head-to-toe complete exam, including digital rectal exam. And I think this is very important in patient with suspected pelvic hemorrhage, because as I've outlined previously to you, there can be additional concomitant injuries in place in the context of a severe pelvic fracture. Stability, who does in the audience, who does stability testing in pelvic injured patients? Who does it? You do? Although it has a very low sensitivity, why do you do it?
I've been doing this for 30 years. It's just
okay. It's just a habit. Yeah, I think this is very important. I was just about to ask how you do it. Because then you open actually the pelvic and potentially the clot. Do you assess pelvic injuries in the pre-hospital setting or in-hospital setting? Yes. How do you do it? The same way or different? Okay. And what is the percentage of patients that do arrive in your hospital with the pelvic binder in place? Is that almost all get it? Almost none get it. I remember you were one of our sessions last year, right? On the chest injury, yeah. However, but How come that it's not? I mean, where are you from?
I'm a contractor. I work all over the country.
Okay. Which country? Okay. So why is it that, I mean, the U.S. military has been very active in promoting the use of tourniquets and based on their experience in Iraq and Afghanistan. But how come that such a, I would say, it's not very expensive, a tourniquet. It's not very expensive, pelvic bag. You can even use non-commercial sheets.
A large part of it's dependent on the education level of the EMS providers. So one of the hospitals I worked at, the EMS was not very good, and every little cut and bruise had a tourniquet on it. And a lot of times it was just, most times it was just venous bleeding. So they didn't have the clinical acumen to ascertain whether it needed to be placed or not. So they got placed many times inappropriately. I think also the level of training, they didn't feel comfortable putting binders on, or they didn't feel comfortable making that sort of diagnosis. So they just didn't do it. And keep in mind that the greatest number of traumas that we have in the U.S. is ground level falls. So those are all. Yeah.
Well, I think that's basically reflecting demographic change world. I mean, at least in the developing world. Yeah.
So about tourniquet in Paris now, after the terrorism attack, in each pre-hospital ambulance we have. So it's. We have now more and more patients who arrived at the hospital with a tourniquet.
Also a pelvic binder. So obviously this is not rocket. This is probably not new for you. I mean, the gold standard in CT in pelvic injuries is contrast enhanced CT, because it also allows you three-dimensional bone reconstruction to plan your surgery, and contrast also increases to your ability to find other injuries, especially if you do phase dependent CT scanning. And obviously, you're able to detect concomitant injuries like nerve injuries or vascular injuries. And I found this a very practical approach. First of all, to identify which problem are you dealing with in your clinical setting, in your emergency department. And also when you want to plan what you want to do next in a patient that essentially is bleeding and it obviously has sustained a severe pelvic injury. Does anybody know this algorithm, or are you familiar with this algorithm? I think it's a consensus-based algorithm, and we have implemented this. I would say rather simplified algorithm in our daily clinical practice, because it highlights the two major problems. And the first one is hemodynamic stability or instability, and the other one is mechanic stability and instability. And those information, both in combination, they would easily guide on how to approach and further treat these patients. And the mechanic stability is quite easy outlined here in this classification that has been on the market, I think, 1 or 2 decades. But it basically drives your the classification based on the force that was essentially applied to the pelvis. So this LC stands for lateral compression. And lateral compression, as outlined by the colleague already, is what we usually think is or consider as a stable injury. The anterior-posterior compression injury, usually where the SI joint is affected, especially in those fractures type 2 and 3 here, and combined with the rupture of the anterior symphysis, this obviously leads you into an unstable situation. And the most unstable situation is when, addition to this APC, there is vertical shear stress applied, because this automatically disrupts the SI joint rupture and the symphysis or the parasymphysis fracture here onto a very into another plane, and gives you a very unstable situation. So this is basically what you deal with when you talk about anatomic stability or instability. And then obviously this information is then combined onto a hemodynamic stability, stability, and this ultimately goes then into the Wes's grade classification 1 to 4, also considered minor to moderate or severe injury. And once you have done this, this gives you this very practical outline how, once you have classified your patient based on the anatomical injury and the hemodynamic stability, instability, and this easily guides you then through these algorithms. And as you can see here, this is the key question, whether you need to be fast in diagnosing and treating in your action, because it's basically driven by hemodynamic instability, or you deal with a stable patient, which you can basically go into the CT scanner and go all this through then in your further management of these patients. So Jacques, is also this the approach you do, or you have a different approach in Paris?
Yes, it's after we have a clinical case, so you can react and give us your strategy. But when we have to deal with an unstable patient, first, what is an unstable patient? Because you have unstable patient with a good response to fluid, and we have unstable patient without good response. And it's different. And when the response to fluid or vasopressor is okay, we try to go to the CT scan, even if the patient is unstable, just to be sure of what we have to face. How many bleeding, just one or two, and just to have a total picture of the patient, and to be able to have a discussion with the surgeon, with the radiologist. So it's, for example, if I take this algorithm, I can see the REBOA. We will talk about this. But we try the most we can to go to the CT scan before going eventually to the operating room or before going for embolization. So it's just the response to treatment is very important.
But how much time do you allocate to judge your response to treatment?
Yes.
And is it like, because if you say, okay, I load the patient with fluids, on the one, so he reacts a little bit, he reacts maybe for 20 minutes, but then he goes down because he's got a hole in his system and blood goes into the pelvis, or fluid goes into the pelvis without any counter pressure. Do you load the patient, for example, with 1 liter, 2 liters, because this makes coagulation system bad?
Yes.
So I think that's I mean, how does that fit into the concept of small volume resuscitation, permissive hypotension? So how does this fit when you make the decision? So this patient remains unstable. It's not like a borderline or whatever.
It's a quick decision, because when the patient arrived to the emergency room, we immediately see if is unstable if we have a good response. And this takes 20 minutes. So in 20 minutes, you can know if how important is the hemorrhagic shock and the bleeding and how you can support it. So in my decision, when I have to take this patient in charge, after 20 minutes, I know if I can go to the CT scan or if I am not able to control the arterial pressure. For example, if my arterial pressure, my systolic arterial pressure is between 45 and 50, despite the fact that I give fluid and vasopressor, I will discuss with the surgeon to go immediately to the operating room. But if I look at the number of patients that we have where we are obliged to go directly to the operating room, it's very rare. It's maybe during the last year, it's 4 or 5 patients reported to 300 patients. So it's not a lot.
Thanks a lot, Michael Kazar from Leuven. I have a question with the scheme you just, the flow chart you just showed. Now, I don't work in the emergency department, but do quite some trauma in our ICU. The problem for me with saying pelvic trauma and then stable or unstable is that if the patient is unstable, you assume that this should be linked to the pelvic trauma, but it might also be linked to something else, a high spinal. But that's something we don't know when we stand in front of the patient, do we? At that point, or am I wrong? I mean,
well, this is probably an algorithm where you anticipate to a very high degree that usually that the major bleeding source or source of the reason for instability is due to pelvic disruption and associated bleeding from the retroperitoneal space into a potentially increasing cavity that's forced or due to pelvic disruption.
And the EFAST is a very the crucial tool to have a first idea of what is the bleeding source.
I wanted to ask, I actually came so that I can tell my colleagues that in France and in Germany, they do it differently. Because our problem is not the unstable patients. Our problem are the stable patients with the pelvic binder, because then the orthopedic surgeons are like, oh, okay, it can wait, go to the ICU. And that is for us a challenge, because we have a patient that we cannot move, that is at risk of worsening and all the tissue damage. And so I wanted to ask, what are your time constants when you have a patient on a pelvic binder that in the emergency department they decided for whatever reason that they're not taking it off? When should this patient go to surgery? Because that is an ongoing problem for us with this temporizing measure that becomes intemporal.
So the key to go directly to the OR essentially is outlined here. If you have a hemodynamically unstable patient, what you want to then do is, I have some slides later, I don't know, but I think we are running a bit out of time. But these are your options. You do preperitoneal packing. You close the pelvis through temporary mechanical stabilization by external fixation. If you have a bleeding from a vascular injury that's potentially accessible through endovascular, if it's an endovascular procedure, then you go to endovascular, to angio, and then this basically, the problem should be at least saved or solved for the first 48 to 72 hours, because on the other hand side, you take care of the coagulation system, you restore hemostasis, and then basically once you have done this, you have you have all the time of the world to get the patient onto the ICU, and then you can damage control, and you can do later stage approaches on for definitive care. Okay, so these patients, if you're able to go to the CT scanner, have the patient under resuscitation to the CT scanner, the major problem is when you open the pelvic binder to assess whether you really deal with an open book fracture or not. Because what we quite frequently see is out on the field by EMS, pelvic binder is, I mean, we are happy. We're very happy. And if we finally, we have all the EMS trained to use pelvic binders and tourniquets. So we don't want to change that. Probably a little bit we have an overuse. We are seeing an overuse. But it's better than have one case in surplus than one case less. So when these patients, what we do, when the patient comes in, then we do a plain X-ray with the pelvic binder, and we open it under hemodynamic monitoring and see how the patient behaves once you have released the binder. And when we do another X-ray, AP plane, and then you see if you really deal with an unstable open book type that needs an external fixator, then you close it to take the patient to the CT and then to the OR for external fixation. Maybe combined with open laparotomy if you have EFOS positive, or you do your peritoneal packing. So if you let's put it this way, if you don't see that the symphysis and the posterior ring is severely injured or disturbed, or if you have an SI space of, let's say, 2 centimeters, and if you don't have an open symphysis, you leave the binder, because if you leave the binder on, put the patient on the ICU, and leave it on there for 25 seconds, you will have a huge problem with the pressure injuries from the binder. So if you have a stable, there is no need for external stabilization or a pelvic binder. If you see it on CT scan, then you just leave it off. And then you do your coagulation management.
I want to make my question clear. Perhaps I wasn't clear. I'm talking about patients that are hemodynamically stable, either because they are stable or because we did something to them, and now they're only mechanically unstable, and they have a pelvic binder. And the orthopedic surgeons don't want to take off the orthopedic binder.
Why?
Either because it's mechanically unstable, or they are worried. They took off the binder, they saw the X-ray, they didn't see something that requires, in their opinion, emergency surgery, but they say, oh, let's keep the binder on.
Why?
So what would you do in that case? The mechanically
and you need to
unstable
no. I think what's very important is you need to have a picture. You need to have a pictorial idea. Let's put it this way: how the pelvic ring is either open or or closed. In one picture with and one picture without the pelvic binder, and then you make your decision. Yes. Or you have the patient in the CT scanner but without the binder. Because if you have a binder, you only have indirect signs for potential...
the patient had the scan, had the X-rays, had everything.
So if he's hemodynamically stable, and if you don't have a type 2-3 Burgess-Young classification, I mean open book SI dislocation injury, leave the binder away. Why do you need a binder? You neither need mechanical nor binder stabilization in these patients.
I'll ask differently. If a patient needs surgery, he's on a binder and he needs surgery.
Why does he need surgery?
Because the pelvis is unstable. How soon do you take him to the OR? On a binder, mechanically unstable, hemodynamically stable. How soon do you take him to the OR?
If we make up the indication that this patient needs stabilization, then we take him to the OR, but for external fixation, damage control. That's quite simple. So yeah, very, very, very easy. You can even do it. You can even do it in the. You can even do it in the resuscitation room. Very simple. Iliac crest and just and this is more sophisticated. This is supraacetabular pin location, but this is probably more stable than this one. But it's an easy, straightforward approach. But the question is, does this particular patient that you are seeing in your emergency, does this patient need stabilization? And if you have a type 1 compression fracture, where you basically have no open symphysis, you have no disruption of the posterior ring, you don't need any stability. You put the patient on the ICU for observation, you do nothing, except hemostatic resuscitation.
Okay, maybe we can move on the clinical case. So it's a 30 years old patient, and he had a motorcycle accident, high cinetic, and there is an immediate loss of consciousness. And at the arrival of the emergency team, the Glasgow Coma Scale was okay, no neurological deficit. The blood pressure was a systolic arterial pressure of 130, a diastolic at 62. The heart rate was 100. The saturation was okay. Respiratory rate was 18. And the hemoglobin 11.8. There is the capillary hemoglobin. There is a mistake. The capillary hemoglobin was 15.7, and so there is pain at the right hypochondrium and at the spine. And the patient received paracetamol, morphine, and a small quantity of volumic expansion, 250 milliliters in the spirit of low volume resuscitation. At the arrival at the hospital, the patient was conscious with spontaneous ventilation. We require only 3 liters per minute of oxygen without sign of respiratory distress. The arterial pressure was lower, 84 systolic arterial pressure with a heart rate of 100, and the MOQ, the hemoglobin was 14. And the pH was 7.32 with a lactate 3.4. The EFAST was negative. So we decide to give more fluid, and the norepinephrine, we start norepinephrine 0.3 microgram per kilogram per minute. So what is your feeling about this patient, and for you, what is the next step? What do you think?
Yeah, we can go to the CT scan.
Yes.
Yeah.
Is it okay for you to go to the CT scan?
Yeah, we tried the. We challenge resuscitation response for the patients, and if the patient have a good response to the resuscitation, we can go to the CT scan, I think. Yeah.
Okay. What is your feeling about the discrepancy between the fact that initially, when the pre-hospital team give us the information, they say that the patient was stable. And 1 hour after, when the patient arrived at the hospital, you can see that there is an hypotension. And so the hemoglobin was high. So what is your feeling about this?
You bleed whole blood, so the hemoglobin won't drop until you dilute him. So this patient is in shock. He needs blood products, and assess the response. That would be my feeling, because he's on noradrenaline. If he's 30 years old, he's on noradrenaline, he's in shock. Probably hypovolemic, unless it's spinal.
Yes. So what is, we make, when we give course, we largely promote the fact that we have to try to decrease the fluid expansion. And so you can see that they did this. 250 meters, it's very small quantity of liquid. It's why the hemoglobin doesn't change, okay? But you are sure that the patient is deeply hypovolemic. So it's the good thing is that we think that the response will be great. And when we give fluid, we have a good response in terms of arterial pressure. So it's for us, it was a good sign to think that it was possible to put this patient in the CT scan before everything. Okay? We discussed with the surgeon because it's you have always to remember that it's an all-team story, and it's important to have here the advice of the surgeon. And you can see that the EFAST was negative. So with the EFAST negative, so you are practically sure that it's not a thoracic bleeding, it's not an abdominal bleeding. So if there is no injury at the limbs, you are practically sure that it's a pelvic bleeding, okay? So the EFAST is very important to, in your mind, to make the diagnostic. Okay, we went to the CT scan, and you can see that, we have a pubic symphysis disjunction. We have a dissection of the intern right carotid artery. Just it's remember that it's very important to check everything at the CT scan. We have a fracture of the right hemisacrum with right sacroiliac joint damage, and a fracture of L5, and with a retroperitoneal hematoma. So with fluid and norepinephrine, the patient was stable. We discussed with the surgeon and the radiologist, and we decide to go for embolization. So we perform embolization, and so just about the pelvic blinder. We perform an injection with and without the pelvic blinder, just to be sure that we don't miss something, just before embolization, okay? So I think it's important to do this. And so the patient, after embolization, the patient was stable. And after, one day after, just for logical, because we have room at the operating room, we fix the pelvis orthopedically. Yes, we took off after embolization. So just to respond to you. So it's really an all-team work. So we have to discuss, and at what point we have to try to do things the faster we can. Even after stabilization of the bleeding, it's very important to try to fix the pelvis as soon as possible, because it's very important to try to not to stay too long in the ICU. So I don't know if you have a question about this, or if you are agree with this strategy or not.
Can you comment on the use of abdominal binders and vertical shear fractures?
Sorry? On the pelvic binder? Yes. And, it's, for example, when we have to deal with this patient, it's a detail, but it's important. When we have a pelvic blinder and we insert catheter in the femoral artery and the femoral vein. So we just, sometimes the blinder we try to move a little bit the blinder to insert the catheter, and after we replace the blinder.
I think your question was related to vertical shear,
Yes.
to C-type C fractures.
Yes.
It's, I don't know, but if you have such a component, pelvic binder probably, because what the pelvic binder does essentially is it closes the ventral pelvic ring. That's all it does. And it provides counter pressure. So if you have a combined, if you have combined anatomical features within your pelvic fracture, your complex pelvic fracture, and you need counter pressure, and you want to close the anterior pelvic ring, then a pelvic binder is probably a good thing to do. But yeah,
Yes,
that's because. Yeah. Again, that's. Yeah. Yeah, because this is you only can. So you're using an external device, let's say, to promote the increase in intra-abdominal or intra-pelvic counter pressure. But then it's also a matter of dosing, I think, as you correctly pointed out. You can do it under fluoroscopic control, and I think this might be because you don't want to execute or to promote additional injury by using the pelvic binder if you do it
it's
too
very
stiff.
important to make things simple. During the pre-hospital phase and in the hospital phase, what is important? Not to miss the pelvic blinder, okay? If the pelvic blinder is not efficient, it's not efficient. But what is important is to have a protocol, and don't forget to put the pelvic blinder during the pre-hospital phase and in the pre-hospital phase. If it's not efficient, it's not efficient. Most of the time, it's efficient. So I think it's very important to make things clear for the pre-hospital team and for the hospital team.
In the vertical shear, the issue is also, this comes also from the military aspect of pelvic binders, which is you want to immobilize. Because one of the problems is that when you're transporting the patients, when you're moving the patient from bed to bed, if you have a complex transport with a field ambulance, with a helicopter, and the patient is moving and everything is rattling, that can create a lot of trouble. So even if it's not necessarily indicated to close the anterior ring, even there's vertical shear or you're unsure, I think the pelvic binder, and I agree, not with a lot of pressure, is very important also for pain control as well.
Yeah, correct. I think that's a nice close. Okay, we have another last comment.
I just want to know if this patient doesn't have active bleeding on the CT, did you perform an embolization?
No, he has a blush at the CT scan. So, but sometime we don't have, and so there is when you don't have a blush, you can have a venous bleeding at the pelvis, and the discussion is: do we have to do something or not? It's really dependent on the stability of the patient. If the patient is unstable, and if you have another source of bleeding, we will perform embolization, okay? So even if there is no blush at the CT scan, just to try to decrease the venous bleeding, even if we don't stop it, but we are able to decrease. So for us, really, embolization, it's the crucial first step to control the bleeding, largely before surgical procedure.
So thank you very much for coming. Thank you for the discussions
Thanks a lot.
and great conference. Thank you.